To continue, we have 4 panel of reactors, and the first reactor is Dr. Raymundo Resurrecion. He will be reacting on Dr. Chris Bleeker's lecture. Dr. Resurrecion is an associate professor of De La Salle University Health Sciences Institute in the Philippines, and a national director on Advanced Trauma Life Support course in the Philippines, head of the Surgical Intensive Care Unit at Quirino Memorial Medical Center, a faculty in Ateneo of School of Medicine and Public Health, and a diplomate and examiner of the Philippine Board of Surgery. He is a program head, Surgical Critical Care, and Trauma Surgery Fellowship in Quirino Memorial Medical Center. Dr. Raymundo Resurrecion.
Dr. Chris Bleeker delivered a very comprehensive discussion on trauma-induced coagulopathy. Much of what we know about coagulopathy in trauma continually changes. To say it is multifactorial is an understatement, and it is now clear that bleeding in trauma is simply not iatrogenic nor delusional in nature, but more complex. It primarily is the effect of shock and injury itself, but thrown in the mix, as he discussed, is endothelial damage, microcirculatory compromise, hypoxia, and inflammation, causing further bleeding and exacerbating shock. A most striking statement was the choice of fluid for resuscitation, which is whole blood. There are newer methods that allow us to assess coagulation in a dynamic manner. This includes viscoelastic hemostatic assay, such as the TEG and ROTEM. Dr. Chris Bleeker emphasizes the need to preserve microcirculation and address oxygen debt caused by hemorrhage to address coagulopathy instead of simply giving blood products. Key messages to prevent and treat trauma-associated coagulopathy is getting the patient without delay to the right facility, permissive hypotension until hemostasis, minimizing the time from injury to definitive surgery, and for the severely injured and bleeding patient, empiric, balanced transfusion therapy to prevent dilutional coagulopathy, and using coagulation factor concentrates, such as cryoprecipitate, rather than just plasma and platelets. Unfortunately, in civilian practice, where the demand for blood products far outstrips supply, trauma care providers must have a low threshold to initiate damage control surgery when faced with a massively bleeding patient. Also, the lack of a pre-hospital system and trauma centers in many of our countries make permissive hypotension a default modality in the severely injured, and therefore should not be given additional time of low blood pressure. Instead, these patients should be rushed to the operating room. Finally, in more austere settings, we must not underestimate the value of keen clinical judgment to identify and arrest bleeding urgently, as well as the value of empiric balanced component transfusion therapy. It's been my privilege to participate in tonight's activity. Thank you and good evening.
I would like now to introduce Dr. Max Lee Chien to react to the second talk to Dr. Louis Ng on analgesia. He is the Executive Director, Johns Hopkins University Alumni Association, Taiwan. He was immediate past president, Formosa Association for the Surgery of Trauma. He is the current attending physician, Department of Emergency Medicine, National Cheng Kung University Hospital in Taiwan, as well as a director, International Medical Center in Taiwan. Over to you, Dr. Max Lee.
I'm a surgeon. I got training a little bit in the Los Angeles County Hospital, and I used to be the trauma center, the director of trauma center for a while. So I want to emphasize on that the importance of the surgeon. I think the pain control, the breathing. Sometimes we need a radiologist to do the angiography to stop the breathing, or even to call out the surgeon in the middle of the night to call them out to ask them to operate on it to stop the breathing. Because I think sometimes the control of the breather is the most important thing. So I hope to get any further question to asking about that. Thank you so much.
Our third panel of reactor, he will be reacting on the lecture of Dr. Chien. Dr. Jesus Fernando Inciong, he is the president of the Philippine Society for Parenteral and Enteral Nutrition, an associate professor of surgery, WHQ Memorial College of Medicine, St. Luke's Medical Center. And he is the head Center for Weight Intervention and Nutrition Services in the same hospital. He co-chairs the Committee on Surgical Training under the Philippine College of Surgeons. And he is the chair of the Surgical Nutrition Study, the Philippine Society of General Surgeons. An editorial board of Journal of Surgical Metabolism and Nutrition, and a past chairman, president of the board, Nutrition Foundation of the Philippines. Let us welcome Dr. Jesus Fernando Inciong.
Thank you very much for that kind introduction. You know, that was a very lengthy discussion on the nutrition in the trauma critically ill patient. Just a couple of things you need to remember, that every ICU patient is actually at risk of developing nutrition-related complications. In particular, perhaps it's trauma patients. Therefore, if they're staying longer in the ICU for more than 48 hours, we should be screening these patients for possible nutrition risk. And it has changed already. The criteria for the diagnosis of malnutrition has changed. Lately, we should be considering likewise, you know, changes in body composition, because the effects of inflammation actually elicits a different response in the body. And this may lead to nutritional complications in our patients. So, excuse me, you would be seeing so many studies on perhaps ultrasound on the rectus femoris muscle, taking a look at its effects on the long-term effects of your critically ill patients. Of course, you will hear about abdominal CT scan, the level of L3, and looking at skeletal muscle mass, the psoas muscle diameter, and even the fat deposition in these muscles, all affecting possible outcomes in our critically ill patients, especially our trauma patients. So it has changed. And perhaps in the mechanically ventilated trauma patient staying in the ICU for a long period of time, you will also see studies measuring the diaphragmatic muscle and how this affects the ventilator-dependent dysfunction of that diaphragm. So we now know that the changes in body composition leads to malnutrition and likewise leads to more complications in your critically ill trauma patient. But we need to remember that the priority in the acute phase of critical illness is actually resuscitation. And your nutritional intervention will only be secondary or as an adjunct to the other treatments that you're giving your patient. There's no question about it. When you want to give nutritional intervention, the priority should be through the gastrointestinal tract, whether you have an open abdomen or whether you have an enterocutaneous fistula. As long as you can give some amount of feeding through the gastrointestinal tract, you're now taking advantage of both the nutritional and non-nutritional benefits of feeding through the gastrointestinal tract. And there's only one absolute indication to total parenteral nutrition, and of course, that's intestinal failure. However, there will be times when you will need to combine both enteral and parenteral nutrition, especially if you're not hitting your energy or protein goals. In the initial acute phase of critical illness, there's no reason for us to give a lot of energy in our patients, because we now know that in the early acute phase of critical illness, overfeeding is actually bad. So if you are part of that generation of surgeons who are very familiar with hyperalimentation, then perhaps you should reconsider the way you're giving nutritional therapy. So now we understand in the first week of critical illness, while you're stabilizing that patient, then you're slowly just ramping up the amount of energy and calories that you're giving these patients. So the key here to remember is avoid overfeeding. And unfortunately, our predictive equations, our weight-based equations have been found to be inaccurate. And the best way to determine the energy requirement would be using indirect calorimetry. And hopefully in the future, more institutions would be having this so that we'll be able to give and deliver adequate nutritional intervention to our patients. You will also notice that in the latest guidelines, they will tell you not that your serum transport proteins are not a good indicator of your nutritional parameters in your patients. And why is that? Because your serum transport proteins, or serum albumin, your serum prealbumin, are part of the acute phase response. Therefore, in the early or in the acute phases of injury, these are expected to be going down. And if you're monitoring your serum albumin levels, then it will be inaccurate in terms of the nutritional delivery. In fact, if you're taking a look at the studies done by Dante in the Massachusetts General Hospital, he will show you that, no matter how good you are in the delivery of your energy and protein goals, it is not directly correlated to the amount or to the levels of your serum transport proteins. Therefore, we should perhaps be looking at adequacy of delivery of our nutrients instead of looking for a laboratory parameter to monitor our nutritional delivery in our patients. So in essence, there's a lot of research now going on in terms of nutrition, especially in the critically ill patients, and perhaps in the future more on trauma patients. And most of this research in the past decade actually started to increase in the last 5 years. And so guidelines have been changing very dynamic in the past 2 years. And so perhaps in the future, there will be more advances in this science, which will guide us better in how to deliver our nutritional intervention in our patients. But as of now, what we should remember is it's not really the calories that's very important in the first few days in the ICU, but it's the adequacy of delivery of our proteins. So temper your calories, take note of your proteins, and perhaps we will be more successful in the future. Thank you.
So we come to the last reaction by Dr. Karma Jayasuya, who will be reacting to Dr. Lowell Ling, the topic on antibiotics. He is someone that known to us in Singapore. She is a consultant surgeon in district-based hospital, Dambulla, Sri Lanka. He is also a director, National Trauma Management course, and a fellow International Society of Surgeons. He is a Sri Lanka representative for Asian Collaboration for Trauma. He's an international instructor for definitive surgical trauma care course and advanced trauma life support. Please welcome Dr. Kamal.
Hi, Jerry. Thank you very much for the kind introduction of me. So I hope that all of you can remember the last slide of Lowell. It's a gray zone, and he was looking at a big blackboard and how to tackle this antibiotic requirement in trauma patients. So actually he entered the talk saying our goal of giving antibiotic is to improve the survival, but there are some problems of giving antibiotics. So how can we adjust it and balance it? Actually, in classical trimodal distribution, earlier explained, the late deaths of organ failure and sepsis also now flattening. So there are some good discussion by him saying that there are some evidence, but conflict of evidence. So if you think about few things that we used to do some sort of single dose antibiotics. Now, no evidence for that in severe trauma. And all IC2 patients, we used to give antibiotics earlier, but no evidence for those things as well. Actually, he clearly mentioned, and I want to elaborate a little bit. Now, if we can reduce the dose and the prolonged course of antibiotics by other supportive measures, the goal of him or the discussion of that antibiotic side effects versus the survival rate will be improved. I think probably Professor De La Cruz also agree with me, it is said that the best antibiotic in open fractures offer good wound toilet. So it's a surgical support to reduce the requirement of antibiotics. And then main problem in sepsis, and as he said, the differentiation of sepsis and the infection is very important, because treatment of sepsis is different and treatment of infection is different, and we can adjust the doses and the course of antibiotics. So ventilatory associated pneumonia, the VAP, though as he discussed that even the imaging, it's very difficult to interpret with, like lung contusion and pneumonia, whether that is nosocomial pneumonia or the lung contusion even in imaging. So in that kind of situation, the anesthetists help, and the use of other measures to support the ventilatory support to reduce the dose of antibiotics is another side of in this discussion. So what we can do actually the low pressure ventilation, and we can, if you use, sometimes we have to use the PEEP in certain situations with the deterioration of oxygenation and all. So we have to balance it. And if we can think about extracorporeal membrane oxygenation, the use of that in VAP, that is ventilator-associated pneumonia, then we can think about reduce our antibiotic use and the prolonged doses. And of course, early tracheostomy will help us. And certain institute will go for pulmonary toilet as well. Okay, so as the last reactor of this lecture and this session, I want to give a message to all of us, all of our trauma-related colleagues in this antibiotic use and overcome the side effects and to reduce the prolonged use of it and use the appropriate antibiotics. It is essential, all of us to as clinicians, to revise and assess the antibiotic regime daily. Then we can think about his last comment of his lecture, which is de-escalating of the antibiotic regime. We are, all of us are known that prolonged antibiotics, continuation of antibiotics, sometimes the junior doctors will remind us that is not the standard. So we have to assess it daily to reduce, and de-escalating of antibiotics is very important. I think one of the nutrition part, the early enteral feeding also help in this reduction of antibiotic use. Thank you very much for inviting for me to react the lecture, and we'll enjoy the rest of the webinar. Thanks.